I'd now like to welcome Professor Chris Mitchell to chair the next panel, which is on implementation, which is on implementation and embedding research into the health system. So I'll hand over to her.
Thank you so much, Emily, and I really enjoyed Lisa's talk, and it's going to be wonderful to have her as a panelist on this session. So this session is on introducing to you one of the Academy's big projects for the year, which is to embed research into the health system, which is and a discussion with our panellists, who I'll introduce in a minute, on harnessing research for better health. I'll ask the slides to be put up, please. While we're waiting for the slides to be put up, I will introduce our panel. So our panel includes Jonathan Carapetis, who is the director of the Telethon Kids Institute in Perth and sits on our panel that is undertaking this work for the Academy. He's also a professor at the University of Western Australia, a consultant paediatrician at Perth Hospital, and Perth Children's, and he's interested in rheumatic fever, rheumatic heart disease, and many other areas. Professor Sandra Eades, who is the Dean and Head of the Curtin Medical School. She worked initially as a general practitioner and then started her career in health at the Telethon Kids, and she is currently Dean of Medicine at Curtin Medical School. Vlado Perkovic is the Professor and Dean of Medicine at University of New South Wales, a professorial fellow at the George Institute. His research focuses on clinical trials and epidemiology. And Professor Helena Teede, who is currently Director of Monash Partners Academic Health Science Centre and Director of Monash Centre for Health Research Implementation. She's also an HMRC Fellow. And finally, Associate Professor Lisa Whop, who you've just heard give a fabulous talk. So my job is to introduce to you the Academy project, which is embedding research into the health system. And then I'm going to ask the panel some questions, and hopefully the audience will ask some questions as well. So this project is the Academy's flagship policy project seeking to improve healthcare for Australians by better enabling research to be conducted in the health system. It's been 8 years since the McKeon Strategic Review of Health and Medical Research. This project will explore the gaps that are remaining following the McKeon Review, and also the effects of the COVID pandemic, both good and bad, on healthcare delivery. Next slide, please. So the project terms of reference were developed by the Academic Council in conjunction with the project working group, and we've got two members of the project working group with us today, Vlado and Jonathan. The full terms of reference we've abbreviated here, but basically it's bringing together the evidence on the value of integrating research into the health system to mutual advantage of both the health system itself and for medical research, to consider how we could improve this integration process, and to identify stakeholder roles and responsibilities, how the current landscape should be developed to improve the process of integration and translating research, to identify the most significant barriers, the relationship in partnerships with academia and the health system and the solutions to those barriers, and to identify and make targeted recommendations to deliver on the Academy's vision. The full report is anticipated with recommendations in the first half of 2022, and the project's underpinned by a communications strategy which was launched in August of this year. Next slide, please. So how are we gathering the evidence? So the evidence has been a multi-pronged strategy. We've had a series of round tables, as indicated here, with early and mid-career researchers, medical research leaders, medtech and industry leaders, clinical trials experts, funding agencies, healthcare administrators and academic health science centres, The team have conducted interviews, there's a survey, and we're going to undertake potentially commissioned research to explore the value and cost of implementation. Next slide, please. So evidence is about halfway through with collection, and overwhelmingly the value of integrating research and the value it brings to patients, the clinical workforce, and the broader health and medical research sectors have been recognised. We are starting to identify some of the infrastructure, cultural, organisational changes that need to be made to improve embedding research into the health system. What are the governance challenges, the funding challenges that preclude this, and the role of Academic Health Science Centre in this process? So that is a summary of the project and the emerging themes, and we're about halfway through. I'd now like to take down the slides and, having introduced my panel, put them on the spot and ask them some questions. So I might first turn to Jonathan, who's actually on the panel, who's bringing forward this policy recommendations. What areas do you see as the focus for you, both as a panellist and for you as a leading clinical researcher, of any project recommendations, and what areas do you see as priorities for action?
Look, thanks, Chris, and it's great to be part of this panel. I guess when those slides you just put up, there was one word that stood out for me that I think is the priority, and that's culture. And it's true when you're trying to change any system, when you're trying to change any organisation, culture comes kind of first. And I'm sure I'm not alone on this panel, and also the people who are tuning in. With my experience over many years trying to sort of work as a researcher in the healthcare system, that there's still overwhelmingly in the people who run our healthcare systems, I think there's a valuing of research, but when it comes down to it, I'm not sure there's a valuing to the point where it's seen to be an absolutely essential part of a high quality healthcare system. And I understand exactly where that comes from. I understand all the different requirements of the healthcare system, of the people who run it, people who make policy. But when the push comes to shove, do people who are making decisions, whether they're at the kind of political bureaucratic level, within hospitals, within healthcare systems that might be more primary care related, do they see it as an essential or just a nice to have? And indeed, is it seen to be just one of the many things that they could potentially support? And therefore, when someone who's running a hospital, for example, gets pulled in front of estimates being asked about problems with mortality, problems with waiting lists, problems with budget overruns, that's when I think research is seen to be something separate rather than something that could actually help them deal with all of those issues. And so I struggle with the issue as to when I'm trying to make a case for how important it is, if you really want to be world-class as a health service, that research needs to be an essential and integrated part of what you're doing for all the reasons that you've outlined in your opening slides, to really get that traction. And I do think the evidence we still suffer from a lack of truly objective evidence. When I've really looked into it, it's only now starting to come out particularly from the UK. There's some data that are coming out, some peer-reviewed publications about how places that do have really research-intensive healthcare environments have better health outcomes, have better staff morale, have better staff retention. We've always said this, but we haven't had the real data to put behind it. I do think that we don't hold, and I don't want to put this on the healthcare systems alone, because I think researchers have been just as much to blame as kind of being on the edges and not really understanding the world of healthcare service delivery enough. But we haven't had a research prioritization, or we haven't had KPIs for health services around research. And that comes back to how we really make a case for the importance of this. I think the UK obviously is seen as the leading example, and we have a lot to learn from them. But that came down to champions really at the top that said, we are going to make this happen, and we see it's important. And that's led to all sorts of things, including, you know, accredited training pathways for academic clinicians that, again, we don't really have well enough in this country. So I think that's the challenge for us as clinician scientists, is how we change culture, how we make sure there's prioritization. I do believe that in this country, with our Commonwealth, state, local challenges, we do need to work at all those levels, but I suspect that for most of us, a lot of the ability we have to influence change might be much more local than it is going to be at national level. And so working with your own healthcare system and really trying to work from that bottom up, I suspect will be a much better approach. So I'll stop there.
Just a follow-up question. You mentioned the state-federal divide. How much do you think that is impacting on implementing healthcare more, research more into the healthcare system?
Oh, look, I think it's a big deal. I do think that that when it comes to research at the federal level, it tends to be put into funding schemes rather than integrated into the way the healthcare system is supported. And when it comes to it, we all know that the hospitals, for example, get this teaching, training, research funding. We know that in most hospital environments that is somehow not specifically allocated to, for example, research. And I think there's it's kind of because there's not a single system that is able to hold people accountable for what the research, not only what research spend is, but what the outcomes are. And so I do think that's what kind of why I'm increasingly focusing on my own place to see whether or not I can change and demonstrate value from the bottom up.
Yeah, sure. Thank you so much. Might now go to Sandra. Sandra, I've got a question from the audience, and also I've got a question for you. So formal clinician researcher pathways play a large role in research integration in a number of other countries. How do you see this approach working in Australia? And a question from the audience specific to growing the next generation of indigenous clinician scientists. How should those programs be tailored? So the first question, it relates to how do we make that formal clinician researcher pathway work better, and then how do we tailor a program that will suit the needs of indigenous clinician scientists?
Chris, I think we're doing better than previously. In recent years, the academic health research centres have been terrific. The MRFF funding for clinician researchers is terrific. I think we need a scheme which is about supporting clinician and translation researchers, and the UK in particular has, you know, a wealth of experience that we could draw on to take ourselves nationally to the next stage. I'm working on different translational health challenges in Indigenous early childhood health and development, Indigenous youth mental health, and Indigenous dementia prevention. But I still feel like the system we've got silos us. Even with the missions, it silos us with our group and our teams. We need to move more towards grand national challenges. Even though I agree with what Jonathan said about working locally and trying to have a local impact in health systems, I think even with the geographic challenges being a much bigger, more widespread country, we can do better to network clinician researchers and translation researchers to solve grand challenges. We've had to do it with COVID-19. There are all these people with siloed pockets of excellence that have had to come together to share that experience. Jonathan's got a terrific program around ending rheumatic heart disease in Australia. We've seen groups of researchers network and come together around hepatitis C, for example. I think there are some supports for clinician researchers, but I'd say we're at least 50% underinvested in this area, both for clinician researchers and for translation researchers, and we still don't have the systems to break down the silos and to network and bring people together in, you know, collaborative solutions to big challenges. The last 2 years I've spent here in West Australia, it's been really evident how hard it is to join those networks from the West. whether it's geography or what, I think we can do better.
Thanks,
The
Sandra.
other question was about
Indigenous.
I think Indigenous clinician research. I think we have to engage with key groups, the Australian Indigenous Doctors Association, the Australian Indigenous Psychologists Association, there's an Indigenous Allied Health Association, there's Katsanam, Aboriginal and Torres Strait Islander nurses and midwives. They have a major influence on students in training and then clinicians throughout their life. We really don't have enough active clinician Aboriginal and Torres Strait Islander researchers. And I've been deep inside a medical school for the last 2 years, and there's an enormous enthusiasm for medical students around research, but I don't think the supports are there sufficiently well enough to tap into that interest whilst young people are students and developing their professional outlook.
I couldn't agree with you more, Sandra. My next question, and I'll integrate some questions from the audience to the whole panel. Next question is to Lisa. What value do you see in further integrating research into the health system, and what are the main barriers? And as a follow-up question based on your talk, you're very community focused in your research. How do we make the community more part of the health system and embed it into community? So Lisa.
Yeah, I mean, it's a big question, and I definitely don't have all the answers, but I think that the way that we value research is, or at least I think not as necessarily as researchers, but how other people perceive the value of research is often the biggest barrier. You know, I use the close the gap example. You know, we've seen pretty slow improvements in Aboriginal and Torres Strait Islander health, and I think that, and we've got a lot of research happening, but I think what happens is often it's perceived that we're talking about individual behaviours, you know, surveillance, versus it actually being about holding systems to account and keeping people safe. So I think that in terms of integrating research into health systems, that has to be the focus. So talking about why it's important, why people should actually care, how it can help with the job that they have to do, i.e. is it about patient safety? It can't be just surveillance for the sake of it or collecting data with no kind of foresight. Not suggesting anyone is saying that, but I think we have to be very clear about how we communicate why it's important and how it can be useful to the health system. This is not necessarily a health system, although I guess it kind of is example. I've been working with AHPRA, the regulatory body, for the last couple of years, particularly on their cultural safety strategy. And one of the questions that we came up with was really understanding how do we know that we can improve the cultural safety, both for, you know, clinicians, but also for those that may make a complaint, a racial complaint. And we worked out very quickly that there was not really the mechanism to be able to do that well. And I think that's an example of how we've been able to embed a research aspect, sort of a longitudinal aspect, into the regulator, where we will be able to do an assessment of what currently has been put forward as a notification against a practitioner that does have a racial complaint element to it. And then over time, based on the interventions that we're hoping to do via the cultural safety strategy, we can measure, you know, how that's improved or where we need to focus and strategize. So I think it's really about value and people realising how it can be useful to them to achieve the goals that we all want to do, which is really better outcomes for patients and looking after our staff that work in these health systems. So I think that, you know, the biggest barrier is absolutely value. And I think to say that, you know, we often sit on a pedestal and say, why don't people you know, understand research in the same way? I think it's a very good reason. And we can think about Aboriginal and Torres Strait Islander health being one of those. You know, we have, you know, a history of having research conducted on Aboriginal people versus with Aboriginal people. And I can really understand when communities don't want to have that research. And so it could be the same sentiment that happens for health systems, where they're not really understanding or they haven't had a good experience of how that's to be used. And I think we have to make it so that it does align with their strategic goals. So it's a tool that they can use to be able to do the work that is important.
Thank you so much. I'll now go to Helena Teede. Helena, what do you think this, and I know you could speak for a long time on this because it's a big question, and unfortunately you can't, but what do you think is the role of academic research translation centres and improving integration of research into the health system? I think my perception is they've been incredibly successful. Whether government is prepared to keep funding them is the question, but what do you think their role is?
Yeah, thanks, Chris. And that was a really good lead in, actually, Lisa. I think I'm a NHMRC academic research fellow, and I've come from that background, but my passion in having the opportunity to lead one of these centres and to go on the journey is really that I strongly value the benefit they can actually deliver. And if you think about it, we've actually completely managed to farm out R&D from healthcare, unlike almost any other sector. And, John was sort of alluding to how the UK has managed to overcome that earlier today. But the reality is almost every sector has R&D embedded in it, but we seem to think research belongs over here and healthcare belongs over there. And I think that it's important to put a value proposition to our healthcare providers about what we can offer, but if we can't actually offer solutions to their problems, really listen to their problems and offer solutions that are meaningful to them, much like if we don't do that for our community, then we are just yet another group looking for support, another group looking for funding, and another group that might solve a problem for us, but actually we're not solving their immediate problems. So the centres, to come back to your question, Chris, have really looked to disrupt that disconnect between research and development and healthcare, really focus on establishing a culture, as Jonathan suggested, around the fact that, the community are the funders and the beneficiaries of research and of healthcare in this country. And up until now, they've had almost no say, especially our underserved populations, in what the research priorities and design and outputs and outcomes are that would actually change our health system. Now, the MRFF gives us the potential to do that, but the centres and the MRFF were the two strategies that fell out of the McKeon review. And so really, to me, the centres are about completely flipping the paradigm from excellence in research, which we need to still have to develop the new COVID vaccine and for the blue sky research and a lot of the innovation for new therapies, but to flip it to also be able to address the biggest problems for the community and their understanding of the problems and the biggest problems for the health sector, to then have a research workforce embedded in frontline care that can really do this. And we've heard lots of reference to the silos and the system, but the reality is, Chris, that the drivers for each of us are so different. For universities, it's bibliometrics and grants and papers. And for hospitals, it's flows and waiting times. And for GPs, they're all private practices. And, the community doesn't even focus in there. So if we want a system, and this would not be hard, and the UK has done this very well, actually. If we want a system where people really aim to embed research in healthcare and to deliver a better healthcare system, then we need a system that values that. The UK universities, 25% of their funding is from impact. And I know we're going to go in that direction. Our health service CEOs all of a sudden are about to be accredited for their ability and capacity to do research. It's one of their metrics. And boy, they're at our doors saying, how do we do research? Because it's now one of their metrics. The community is now being given the opportunity, and increasingly it's a requirement that they're involved in these funding strategies. And we're seeing the culture change that Jonathan referred to. And I think that's the biggest thing these centres can and have done, Chris, is to be able to say, it's all about better outcomes for the community and better health system. How do we enable researchers to do that? In terms of big gaps, and I've spent a lot of time in the UK, I've interviewed all the directors of their applied research centres, their academic health science centres and networks, and all the directors across Australia when we were looking at how to structure these and how to work it. And a lot of our community, because we have a strong consumer and community involvement strategy, our CEOs, etc. And really, our biggest gap is our workforce. We don't have an adequate, funded, enabled, trained workforce that sits in clinical roles, that's got time, that just as John suggested, to do this. And in the UK, they do have that. And I think we also, one final point is, we should not necessarily look at the UK as the best at everything. We have a second starter advantage here. There are some brilliant things they've done, but there are also some fundamental problems they have, and they don't collaborate. And the concept, I think Sandra brought it up before, about the fact we only got 26 million people. If we all expect to just compete with each other about these big, wicked problems and don't look at national collaboration opportunities and don't work above jurisdictions, we're really going to fail to make the sort of impact we need to. And the more we work towards that embedded in healthcare, the more the onus is on us to work collaboratively and to listen broadly and to implement widely. And the centres are doing that, and they're also collaborating nationally. But what they lack is the recommendation of the McCann Review that they're actually funded to do this. So I think they've made a big difference. I think
we'll have to, there's quite a few questions coming up. So I think that was a fabulous answer. So thank you so much, Helena. And I'm going to go to Vlado to ask him about clinical trials. John Saville was slightly provocative in his talk, and it was very interesting, suggesting that clinical trials, their change they made meant there's greater enrolments, greater return on investment. How can we change our clinical trials here in Australia to be optimally positioned and truly embedded in the Australian health system?
Thanks, Chris. And I think clinical trials are a wonderful microcosm of many of the other issues we've been discussing over the last 20 or 30 minutes, in that they illustrate some of those points really beautifully. Ultimately, healthcare is about improving health, and the way we do that is by intervening in ways that we only can understand through properly through clinical trials, not only in terms of how they work, but the risks and benefits. So for any clinician, clinical trials and data from clinical trials has to be the fundamental part of their toolkit that they use, they should use all the time moving forward, whether they recognise that or sometimes whether it seems a little peripheral to them. And sometimes we've moved away from that concept, and we've allowed the potential lure of money from industry, from clinical trials, to distract us from the fact that that's the core mission. It's all about how do we improve outcomes for people. So when we look at it from that point of view, then clearly it's fundamental to everything that we do in healthcare, and it needs to be built into everything that we do in healthcare, and we need to look at the factors that are barriers to us moving forward at the moment, and that includes some of the things that we've heard about, the cultural issues, the prioritisation in healthcare, the understanding, frankly, of the roles and methods of clinical trials amongst some of our clinicians, but also the resources they have to both understand and to do clinical trials. Because I'd argue that if we've got something that we don't understand, we should be running clinical trials, and we should be doing that much more routinely than we do at the moment. And that sort of brings us to the other side about what about clinical trials themselves. And again, unfortunately, clinical trials have, as Helena put it, been sort of put way out to the side, so they're considered something entirely separate, whereas they should be what we do every day, and they should be part of our everyday practice. And by making them different, we've made them bureaucratic, we've put complex structures around them that make them, frankly, difficult to do and complicated to participate in. And we need to strip away as much of that complexity as we can to make them answer the fundamental question that we're really interested in, and do that safely, but not do any more than that. So I think, if we recognise that this is one of our most important tools, and seek to try and increase the number and quality of clinical trials that we're implementing, the answers start to become relatively simple, and we're starting to implement a lot of those through initiatives of the Academy, through ACTA, through government, through health services, but we've still got a long way to go, and I hope that the journey continues.
Thanks so much, Vlado. Were you saying that investigator-initiated are more important than pharma trials? Was that what you were saying?
No, I'm saying trials that answer important questions are more important than others.
Just a point of clarification. There's a question from the audience, from Elizabeth Elliott. I'll open to the panel. How can we achieve equity in conditions for clinical academics who promote and conduct research in health services versus their health employed counterparts? So open that up to the panel. Does anyone want to answer that? So the clinical academics who... Yeah.
I could make a comment. So there's been a big push to look at a similar type of structure to what they have internationally, which is actually to value that workforce that you're talking about, people who do research and either research or translation and clinical care, by actually co-funding them. So taking that burden from the health services and by valuing their position, and those positions actually become part of the health service metric. So there's many ways in the system to do that, but it requires a funding stream and commitment in Australia.
Thank you.
I'd like to see every clinician be a clinical academic rather than having them divided into those who are academics and those who are not. I mean, all of us are continuously learning. We're all trying to improve our practice, and we should all be involved in some form of practice improving activity, which you might also call research. So, you know, the arbitrary distinctions that are sometimes made through industrial instruments to those who are clinical academics and those who are clinicians, I think can be counterproductive if we're not careful. And I think what we need to do is find protected time for clinicians who want to undertake research.
I could not agree with you more. Final question from Emily. We're always asking for more research. My health service is always asking me, haven't you done enough? Can't you implement? Stop researching and implement what you've got. I'm interested in the panel's answer to that, so I can tell my CEOs we're going to implement and stop researching. Any answer to that?
Well, I think it's both. That's the obvious answer. And that, so I don't think we have been good enough at implementation science, at health services research, and that's clearly what health services are wanting from us. So I think we need to respond to that need. But I also think we need to really make a case around the fact that we only have one of the world's best healthcare systems because we've had this pipeline of new discovery and new research. And so it's not either or, it's both.
Thank you so much. Unfortunately, time is at an end and there are many more questions, but I'd like to thank all our panellists for a provocative and really interesting session. And I'm now going to hand back to Louise for the next session.
So thank you very much, Professor Mitchell, for chairing our final panel for the meeting, and to our panellists, Professors Carapetis, Eades, Perkovic, Teede, and Associate Professor Lisa Whop.